So for those of you that don't know who I am Philip Mohorn. I'm one of the critical care clinical pharmacists here. Primarily I practice over in the medical ICU, but I'm also on faculty at South Carolina College of Pharmacy, so that's why you don't see me as consistently as you see some of my other team members like Aaron in the back or Bevan or Joey. And so today we're just going to briefly go over some principles with respect to sedation in the ICU and talk briefly about some agents that are used commonly for sedation in the ICU. This is very informal, so feel free to interrupt me at any point during the presentation and ask questions. I tend to talk sometimes a little fast, so if you want me to slow down, don't hesitate to tell me to slow down, okay? All right, so as all good professors, definitely have objectives for the presentation. So we've kind of really gone over these. I really just want to highlight why sedation is important for our critically ill patients, then talk about some of the specific pharmacology and pharmacokinetic principles of the agents that we use, and then just briefly discuss some strategies with respect to sedation. So why sedation in ICU? I'm not going to belabor this point that much because you all know our patients, our patient population. Our agitation occurs in about 71% of the patients in the ICU, all right? And it's due to a number of things, all right? Pain being a big one, procedures, mechanical ventilation, etc. Y'all deal with this on a daily basis, so I don't have to, go over these in great detail. But unrelieved agitation can cause a lot of things, especially in the immediate setting. It can cause ventilator dysynchrony, causes increased oxygen demand, all right? So then it could contribute to decreased perfusion to other organs. And then definitely y'all have experienced all of this, having patients pull out things, all right? Devices, catheters, etc. So another thing that is pretty prominent with respect to sedation is post-traumatic stress disorder. So this is kind of a new phenomenon in critical care. And it's noted about 4 to 15% of ICU survivors. There are a lot of studies coming out now about this with its kind of role with sedation and having post-traumatic stress disorder. So definitely having agitation in the ICU is detrimental to patients. So the goal of sedation is to provide patient safety and then also comfort while trying to prevent all of these complications that we talked previously about. So my first important clinical pearl, all right? So we're going to talk about some of these sedative agents. However, the sedatives all have drawbacks, all right? So in an ideal world, we want something that has a rapid onset of action, all right? Doesn't have any active metabolites that will prolong its efficacy or prolong its activity. Definitely want a large therapeutic window so that we don't get any trouble with respect to side effects. But all of our agents inherently have something wrong with them, all right? So we'll go through some of those things. Also, sedation alone doesn't provide complete amnesia for very stressful events. So I'll briefly talk about analgesia further along in the presentation. And then definitely some sedative agents can cause vivid hallucinations, all right? So patients can see things, hear things, and act out secondary to sedative medications. So that's also important to kind of note. So agitation assessment, I'm not going to go over this slide too in depth, just to tell you that here we use RASS, all right, the Richmond Agitation Sedation Scale. Other places use the Riker scale or SAS to assess for agitation. Y'all are very familiar with these scales, and I really just wanted to have this slide in here just for your reference and to know that these two scales are the most validated scales used for agitation assessment in the literature. So before we talk about agents, what are some non-sedative things that we can do? Definitely making sure that patients are comfortable. All right, so if they don't need lines, if they don't need catheters, making sure that those are removed. It's kind of the small things with respect to their environment. If a patient wears glasses, maybe have glasses at the bedside if they can use them. If they are not mechanically intubated or mechanical ventilation and can use these agents, go ahead and provide them. And then another thing or a big thing that's in the literature is maintaining normal sleep patterns. And so you can do these things by just turning off on and off lights at appropriate times throughout the day. And if that doesn't work, maybe providing some pharmacologic support like melatonin or some other sleep agents to help with them to help prevent agitation. So real briefly, I just want to talk about analgesia. So before any sedative agents are kind of administered, analgesia is probably the biggest thing that you need to have on board. So opioids are our first line of therapy, all right? Followed by some NSAIDs if needed. But definitely opioids are going to be our go-to, so I'm not going to talk about them too much. And then we have some other agents. We'll talk about ketamine a little bit with respect to sedation a little bit later on. So this chart is an all-encompassing chart. I blew it up in the back of your handout for you to have as a reference. I have the first 3 agents on here, but on your handout, you don't have the last 4, and because the last 4 agents are crap agents, all right? So they're not really used in the medical ICU, surgical trauma ICU, neuro ICU, because number 1, they have bad adverse effects. So meperidine causes neuroexcitation, so seizures can propagate that. Also, it has serotonin properties, so it's really not a good drug to use in the ICU. Codeine is just crap altogether, all right? So it has to be metabolized from codeine to morphine, its active agent. And so depending on certain cytochromes that patients have, they may get too much or too little morphine, which makes it unreliable and unpredictable. The other 2, remifentanil, that's really used more in the surgical theater. Very potent, but unpredictable, has a very short half-life. And then methadone, not going to even get into that. Unless you have somebody who's on methadone chronically, then maybe we need to initiate it back in the unit to help them. But definitely wouldn't want to use that as the first line. So really our workhorses with respect to opioid and analgesic therapy are fentanyl, hydromorphone, and morphine. Fentanyl is definitely our gold standard. Number 1, because it doesn't have any active metabolites. Number 2, because you don't have to worry about it with respect to accumulation and renal dysfunction. Hepatic dysfunction, there's some literature out there that shows that it may have a little bit of accumulation, but probably not really.
So Philip, when you say active metabolites, what does that mean?
So active metabolites, so drugs are metabolized by cytochrome P450s, and so sometimes they produce inactive metabolites or waste products, or active metabolites. So, for example, fentanyl doesn't have to worry about that. Morphine, however, does produce some active metabolites. So while you also have the parent drug, the parent morphine that's giving efficacy and activity, you also have the active metabolite that you have to worry about that's also causing some activity.
Okay.
So that's what I mean when I'm talking about active metabolites versus inactive metabolites. Fentanyl is a good drug because you don't have to worry about that at all. You get the parent drug, it goes in, it comes out. You don't have to worry about accumulation. Hydromorphone is the same way, but you may have some accumulation with renal impairment in patients, so it may build up in those patients that have acute kidney injury, chronic kidney disease, etc. What's good about fentanyl and hydromorphone is that they're both synthetic opioids, so you don't have to worry about histamine release. All right, and so that's another big reason why we don't use morphine as predominantly as we use fentanyl, because morphine has histamine release because it's a natural opioid. So the histamine release causes vasodilation, and definitely that's not what we want in some of our unstable patients. Now, it's a good drug because it does have a long half-life, and it accumulates in renal impairment, so that's why you see it more for comfort care. That's why we use it for comfort care, because of that long half-life. But in our patients who we're treating outside of the comfort care realm, it's not a good drug to give as a continuous infusion because of all of its side effects. And so really I kind of just basically summarize that for you all in the slides to kind of have some of those summary points to reference in the future. So moving on to sedation now, which is what we're really here to talk about. Pharmacologic interventions. All right, we'll start with the benzodiazepines and then move on to some other not as commonly used agents, but we'll talk about them briefly. We won't talk about barbiturates at all because we rarely see those because they have a very similar mechanism of action to benzodiazepines. But the adverse effects of barbiturates are a little bit more severe, all right? So they cause the same thing as benzodiazepines, which we'll talk about, but then you get into immunosuppression with barbiturates, decreased CNS perfusion sometimes with barbiturates. So they're very controversial and we don't use them a lot in the ICU. So, like I said, our most common ones are benzos and propofol. Here we see a lot of propofol, and we'll get into that. And then definitely Precedex or dexmedetomidine is not far behind use when looking at these agents. So, how do benzodiazepines work? Well, they facilitate the binding of GABA. So they have a specific receptor or specific site, subunit on the GABA receptor. And when they bind there, they cause an influx of chloride into the GABA receptor, allowing GABA to bind and then cause a sedative effect. Benzodiazepines are very good because they provide sedation. They provide anxiolytic features, all right, so they calm people down. They also help people to forget things, all right, so that's why they're good drugs and good to use in the ICU. And then they have hypnotic or sleep properties. One thing to note, and this is something that goes kind of unrecognized, not so much by nurses, but medical residents. Benzodiazepines do not have any analgesic properties. So definitely let medical residents know that when they put somebody on a benzodiazepine, we'll talk about propofol as well, they need to have some sort of analgesic on board as well, because these do not provide any analgesic properties. So looking at some of the benzodiazepines that we use in the ICU, diazepam, we don't use it as a continuous infusion because it has a long half-life and can accumulate. But we do see it used intermittently for special occasions. But really the focus is going to be on lorazepam and midazolam. Lorazepam having a longer onset of action than midazolam because midazolam is more lipid soluble, so it gets into the CNS quicker than lorazepam. But lorazepam is good because it doesn't have any active metabolites, so you don't have to worry about the active drug or any active metabolites causing prolonged action. Lorazepam is tricky though because lorazepam infusions have propylene glycol in them as a solvent, and so this propylene glycol agent can cause renal issues and renal failure and cause an accumulation of acidosis, accumulation of lactic acid. But you only see that at really high doses and for prolonged use. Midazolam is good, quick on, but very slow off because it does have an active metabolite, so it does accumulate in renal and hepatic dysfunction. And then listed here on the slide are some loading doses, intermittent doses, and infusion dose ranges for your reference. So when we're looking at these agents, if we were to use a benzodiazepine, lorazepam is a good choice in those patients that have renal and hepatic dysfunction, but like I said, we have to worry about that propylene glycol. And then midazolam and diazepam are good for acute agitation because they have a quick onset of action. They get into the CNS quicker. But you have to watch out for prolonged sedation because they have active metabolites. All right, some side effects of benzodiazepines. Definitely they can mess with your hemodynamics and cause hypotension. May cause a little bit of bradycardia, but that's really not what they do. They cause more profound decreases in blood pressure. Definitely you can have some respiratory depression, which we don't really have to worry about because normally we're using these in patients who are mechanically ventilated, so that's really not that big of a concern. If you have prolonged use of benzodiazepines, you may have some withdrawal after weaning or discontinuing it, so that's something to keep in the back of your mind if you start seeing symptoms of withdrawal like diaphoresis, anxiety, them acting out a little bit. It could be not that they're agitated, but it could be that they're used to the benzodiazepine and that you need to watch for withdrawal. And then listed here is if you have some prolonged sedation, you could use flumazenil, which can reverse benzodiazepines. However, I'm not a real big fan of flumazenil because once you use it, it's a pure binder to the benzodiazepine subunit of GABA, so you don't have any reversibility of that. So say you give flumazenil and your patient seizes, what's the first line drug for seizures? Benzodiazepines, so you really can't do anything. So that's why it's not my favorite reversal agent. However, if you need to use it, if you are in like a rapid response situation, then go ahead. But know that if you have a patient who's at risk for seizures, you may be causing more harm than good by using that reversal agent. And then benzodiazepines are also associated with delirium development. And we'll talk a little bit more about that. So moving on to propofol. So propofol has a very similar mechanism of action, like benzodiazepines, both acting on GABA, but propofol binds at a different subunit. It has the same properties, however, its amnestic property is a little bit less than benzodiazepines. All right, so you get more amnesia with benzodiazepine therapy than with propofol therapy. Once again, it doesn't have any analgesic properties, so that's something to remember, remind the medical residents. And then y'all seen propofol, nice little white milky solution. All right, so it's lipid based, so you have to have caution in people with soybean or egg allergy. So propofol, quick on, quick off when you turn it off. No active metabolites. So for the most part, it sounds like a very good drug, except for it has some very unique adverse effects. Okay, and then the dosing ranges are listed here for your reference as well. So some of the adverse effects, so definitely it has some hemodynamic effects. And this really depends on the cardiovascular status of the patient. So if you have somebody who has really profound or severe cardiovascular history, you might see more of a hemodynamic effect on propofol versus patients who don't. And it's really dose dependent. Higher doses, you'll see more hypotension and respiratory depression versus lower doses. It definitely can increase your triglycerides. And this could lead to possibly the patient developing acute pancreatitis secondary to the use of propofol for an extended period of time. The one big side effect that we're worried about with propofol use is propofol-related infusion syndrome. So this is a very big catastrophic culmination of a bunch of complications. So this can cause metabolic acidosis, renal failure, increased triglycerides, severe cardiovascular collapse to the point where you really can't bring patients back from it, and then rhabdomyolysis. All right, doesn't happen very frequently, so the incidence is about 1%. However, when it does happen, mortality is pretty high. All right, so what is propofol-related infusion syndrome? Well, what we think is that propofol interferes with the metabolism of free fatty acids in the mitochondria. And so that's where we think we're getting into trouble with propofol and it causing all the increased metabolic acidosis, lactic acidosis, decrease in Krebs cycle activity, etc. So that's what we're thinking is going on when we have propofol and we see propofol-related infusion syndrome. Like I said, once this happens, it leads to a plethora of different things. You have severe cardiac failure because your cardiac tissue is not getting the nutrients, oxygen, glucose, energy that it needs to perform its job, as well as the other organs, and so you end up with this big cardiovascular collapse. I have never seen it in my practice, and I haven't practiced in too long, but I've never seen it happen. I haven't seen it in training at all. So it is a very rare occurrence. But I have some preceptors and some mentors that have seen it and have told me how devastating it can be when a patient does have propofol-related infusion syndrome. So what are some risk factors for it? So prolonged use, all right, greater than 48 hours. High infusion rates, greater than 70 micrograms per kg per minute. All right, so we typically don't get up to those high of levels when we use propofol in the unit. However, it's something to take into consideration because it can occur at low doses. Concomitant catecholamine and steroid administration. So it sounds like all the things that we kind of do to our patients in the ICU can possibly contribute to causing propofol-related infusion syndrome. But it was first noted in pediatric patients. All right, so you definitely have, that's probably the biggest risk factor, are patients that are less than 18 years of age. So if you ever practice or go over to the pediatric ICU, you probably will never see propofol used as a continuous infusion. So how can you monitor for this? Getting creatinine kinase, lactate, and triglycerides. It's good to get these or advocate for getting these at baseline. So when a patient first comes in, maybe mention it to the medical resident to get these labs up front so that you can trend them if the patient is on propofol for an extended period of time. However, we sometimes miss the boat on that, so if you can get it while the patient is on therapy and hopefully it's not elevated, then maybe you could do some monitoring at that point as well.
Doesn't surgical trauma have a power plan that has something related to propofol testing? Like where you get like ionized calcium too?
Mm-hmm. Yep.
Is there a reason why we don't do that on the medical side?
I do not know the answer to that. And usually I try to tell medical residents to at least get a baseline triglyceride. They're not going to order any of the other.
I feel like that's the only one we really monitor more
Right.
frequently, and that's usually nutrition actually,
Right.
wanting it more so than anybody else.
But definitely I think it's something that we should maybe talk about putting on power plans in order to have it baseline and up front. Because, like I said, the incidence is very small, but definitely don't want to put somebody at an increased risk of having it if we're not tracking those markers. All right, so next is dexmedetomidine, and I like to call dexmedetomidine the baby of the family, even though it was approved in 1999, so that's been about 15 years ago. But that's relatively new in the world of critical care. Dexmedetomidine has a unique mechanism of action. It's an alpha-2 adrenergic receptor agonist, so it has a very similar mechanism of action to clonidine. All right, except for it has about 8 times the affinity for the alpha-2 receptor than clonidine, which is why you get sedation with it. It does have quote-unquote intrinsic analgesic properties. I really don't believe in that with respect to some of the literature that's out about dexmedetomidine and having to use PRN fentanyl when you're using dexmedetomidine. So I don't hang my hat on that, but if you talk to a drug rep, they'll tell you that it has analgesic properties. I just wave them off and ignore them. It does have a pretty quick onset of action, all right? No active metabolites, so it's a very good drug, except for it does have some very profound bradycardia and very profound hypotension. And then the dosing range is listed here for your reference. So the hemodynamic effects are really just a mechanism of how it acts. So it acts on alpha-2 adrenergic receptors. And so if you know anything about clonidine, you know that it's used for blood pressure. It's very good at lowering blood pressure, but can be very tricky to use. And dexmedetomidine is the same way. Bradycardia and hypertension are the most common, but this is dose dependent. So usually loading doses, that's why we don't use loading doses of dexmedetomidine in the ICU because we can drop somebody's pressure and heart rate real quick by doing that. That was demonstrated in the literature in the surgical theater where they were doing it for surgical patients, give them loading dose of that, and then had to initiate rapid response because they were dropping blood pressure and heart rate. Cardiac arrest is also a big concern. And then, like I said, it acts like clonidine, so you have to worry about that rebound hypertension or withdrawal symptom that you have to worry about when you have a patient on clonidine, especially if you use dexmedetomidine for greater than 3 days. That's when I start really worrying about withdrawal. And then respiratory depression is not really noted with dexmedetomidine, which is what makes it kind of a great agent. There's even institutions that use dexmedetomidine on their floors, general medicine floors, in order to calm people down or to provide help with respect to alcohol withdrawal, because it doesn't have any respiratory depression. So that's a good effect of dexmedetomidine. All right, so now that we've gone through some of the agents, really just wanted to talk about some of the literature as to why we use more non-benzodiazepine therapy than benzodiazepine therapy. This is based on the recommendations from the Pain, Agitation, and Delirium guidelines that are put out by the Society of Critical Care Medicine. So this is a very busy slide, but really it's just my attempt at providing a summary of all of the literature that looks at non-benzodiazepine-based sedation versus benzodiazepine-based sedation. In the olden days, it was propofol versus benzos. Really didn't see much of a benefit with one or the other. However, in the 2000s is when we started comparing dexmedetomidine to benzodiazepines, and we saw benefit. We saw less ICU days, less days on mechanical ventilation, but we really didn't see a mortality benefit with respect to using dexmedetomidine. Then there's this thing about delirium. So delirium has been in the literature for a while now and has been strongly associated with benzodiazepines. So in these trials, that was one of the big outcomes, is looking at delirium and whether or not you have better outcomes with respect to delirium using non-benzo-based therapy versus benzo-based therapy. So the men's trial, that first trial in 2007, did show more days alive without delirium. However, that was driven by coma-free days. So it really wasn't a clear delineation of whether or not dexmedetomidine really did provide more days without delirium. In the SEDCOM, however, we did have a pretty big decrease in delirium with using dexmedetomidine versus midazolam. So that's kind of when you hear our attendings talking about it, Dr. Shrib, Dr. Owens, these are the trials that they're talking about that give evidence for using non-benzodiazepine therapy versus benzodiazepine therapy. Now, more recently, we have the MIDEX-PRODEX trial, which attempt to look at dexmedetomidine versus either benzos or propofol, because we were confused about whether or not propofol or dexmedetomidine would be better. That kind of shook out, so dexmedetomidine and propofol are about equivalent to each other, and so that's why they're kind of grouped in that non-benzodiazepine therapy. But however, it did show benefit with respect to dexmedetomidine and propofol over benzos with time at target sedation. All right, so you get better RASS scores. You're able to maintain your RASS goals a little bit better. The duration of mechanical ventilation is definitely shorter using dexmedetomidine and propofol versus benzodiazepines. This one in the case being midazolam. And patients are able to interact a little bit better with dexmedetomidine versus midazolam or propofol, which that kind of makes sense as we talked about its properties. However, in the MIDEX-PRODEX trial, we had this big, so leading up to this trial, we're talking about delirium, and benzodiazepines called delirium, and it's very profound. They didn't really note that in the MIDEX and PRODEX trial. So the neurocognitive defects or effects that were seen in the previous studies with respect to delirium really didn't show up in this. So now we're back at this question of, okay, do benzodiazepines really cause delirium? Are there situations where we can use benzodiazepines for our patients? I think so. All right, so I think the jury's still out. However, you will see our attendings really stick to that non-benzodiazepine sedation use. So propofol or dexmedetomidine. So moving into kind of what I just alluded to, when would sedation with a benzodiazepine be preferred? Definitely if you have somebody with seizures or status epilepticus, it's probably best to put them on benzodiazepine therapy, whether it be intermittent or a continuous infusion, because these are the drugs of choice for status epilepticus. Now, some will argue that you can use propofol, all right, because propofol does work on GABA as well. And I would agree with that. I think propofol is probably a safe alternative. However, if you have somebody who is in refractory status epilepticus, they'll probably have to be on propofol infusions for an extended period of time. and thus we start getting into that realm of PRIS that we talked about, the propofol-related infusion syndrome. So I think it would behoove us to switch them over to a benzodiazepine so that we didn't have to worry about that. Definitely alcohol withdrawal. Once again, benzodiazepines, the drug of choice for alcohol withdrawal. However, once again, you have the argument about propofol having GABA activity as well and maybe providing some benefit. Definitely, if you have somebody with benzodiazepine withdrawal, you definitely want to maybe initiate something with GABA activity. So benzodiazepines would be a good choice there. And then last but definitely not least, what I get on my soapbox about, especially with medical residents, neuromuscular blockade. So when you have somebody who are on neuromuscular blockers, you must sedate them. So I'm talking about goal RASs of -5, like you need to knock them out so they don't remember that they're being paralyzed. You do not get that activity with dexmedetomidine. Don't let anyone ever tell you that. Dexmedetomidine is light sedation. It will not, and it cannot get you to a RAS of -5. So don't ever do that with people who are on neuromuscular blockade. Propofol is hit or miss for me. Propofol, if you give it at higher doses, you probably can reach deep sedation. However, once again, we're starting to worry about adverse effects of propofol. So it's not my favorite agent to have a patient on when they're on neuromuscular blockade, but I can tolerate it as long as we are targeting that goal RAS of -5. But I personally prefer, if we're using neuromuscular blockade, for them to be on a benzodiazepine because we get the biggest effect with respect to amnesia, so them not remembering the event at all, with benzodiazepines versus using propofol, and definitely versus using dexmedetomidine.
Now, I see like our physicians ordering Precedex for alcohol withdrawal a lot. Has that been a barrier for you?
No. So Precedex, so the new literature that's coming out with Precedex in the realm of alcohol withdrawal kind of really goes back to alcohol withdrawal having that big adrenergic effect. So increase in blood pressure, heart rate, those kind of things. So using some agents that act on the adrenergic system is good. So I think we're seeing a lot of benefit with using dexmedetomidine with alcohol withdrawal. It's funny, we recently just updated our CUI alcohol withdrawal ICU protocol, and I left dexmedetomidine off of that because we still have some cost issues associated with it. But I definitely foresee in the near future that we'll probably be adding it to our protocol because the evidence for dexmedetomidine alcohol withdrawal is growing and it's showing pretty big benefit. So definitely I think that's a good agent to use in those patients.
Okay.
Okay, just want to make sure I wasn't missing anything else. Okay. All right, so real briefly, there's some talk about ketamine, all right, and ketamine being used for sedation. We've had some requests. I know Dr. Schrift wanted to use ketamine at one point when I was on service for a patient, but we really don't have any protocols built just yet. So what is ketamine? Ketamine is a dissociative anesthetic, all right, so it's really a rapid sequence intubation drug and really a drug that you use in surgery, all right, so anesthesiology. Its mechanism of action is unknown, however, we do think that it works on NMDA receptors. So if GABA is your inhibitory receptor, NMDA is your excitatory receptor. So if we block that, we still get sedation and we calm patients down. As you can see there, it has sedative effects, analgesic effects, pretty good analgesic. Matter of fact, where I trained at, we use ketamine a lot of times for those with refractory chronic pain. We had them on ketamine drips, but definitely they were heavily monitored. And then it can also cause good respiratory stimulation, so that's why you like to see a lot of pulmonologists use it. For some unknown reason, it helps open up the bronchioles in the lung, so it's very good for rapid sequence intubation, and some attendings like to use it a lot. Onset of action is about 30 seconds. Duration of action, if you're giving it as a bolus, is about 5 to 20 minutes. So it's emerging as an option in sedation for one of two reasons. The first reason is that it really doesn't cause any hypotension, okay? So actually it's the opposite. It'll actually increase your blood pressure, and it may even increase your heart rate, which could be detrimental and cause some arrhythmias. So that's why it's getting a lot of buzz in the literature nowadays. Like I said, I know we've had some attendings who have asked for it, but what's funny about ketamine is that it is anesthetic. So certain nursing laws here in South Carolina don't allow nurses to push or titrate or monitor ketamine without having a physician presence there. So that's where we run into issues with using it as a sedative agent. And also the literature on it is still growing, but it definitely has its potential benefits with respect to it not having that big hemodynamic compromise that you see with benzos, that you see with propofol, that you see with dexmedetomidine. There's also some other adverse effects that are noted, And the funniest one, oh, well, it's not funny. Definitely it's not funny. But to me, the emergence delirium that can occur when somebody is receiving ketamine, so it's really seen more so on rapid sequence intubation. You give them a dose and they just go crazy on you. All right, and it usually happens in those patients who are greater than 18 years of age and who are female. So those are the risk factors for the emergence delirium. And I've actually seen that firsthand. I saw a patient totally like flip out after getting a bolus dose of ketamine. So it's something that you have to worry about. You also have to worry about increased secretions, okay? So it can cause hypersalivation, which may not be beneficial in our patient population as well. But I just really wanted to provide you just a little piece of information on ketamine so that you can be familiar with it. It's not something that we regularly use in the ICU, but it may be an emerging sedative therapy in the future. All right, so just some other strategies. So definitely if we have protocols for sedation, definitely let's use them. Light sedation over deep sedation. So that's why our RAS goal is a little bit lighter, -1 to +1. Want more of that light sedation. Unless you have somebody on neuromuscular blockade, then you definitely need to go deeper. And then you all do daily sedation interruptions and do a great job with that. So that's definitely demonstrated some positive benefit in the literature with reducing ICU length of stay, reducing time on mechanical ventilation. So these are things that we already do. And then definitely getting patients up if they can. So this kind of decreases agitation, decreases the risk for delirium. So these are just some other strategies to kind of optimize agitation and prevent agitation in critically ill patients. All right, with that, I'll take any questions. I know I said I talk kind of fast, but definitely if you have any questions, I'll take them.
Philip, I got a question for you. There's some talk that the amnestic effects of the benzodiazepines actually contribute to or worsen the incidence of delirium in the units. So, I mean, have you read about that? Or?
Yes, definitely. And definitely that's a big association with them having better amnestic properties. So typically speaking, I am not opposed to not using them up front. I think if you can use propofol for, the limited period of time and get good sedation with that, I think that's good. If you can use or have an indication for dexmedetomidine, I think those are good agents as well. However, when we start getting into some of those scenarios where maybe that's not working, I don't think we should be hesitant about switching somebody to a benzodiazepine if the other agents aren't working. But you don't necessarily have to use a drip. So you could also do intermittent bolusing of benzos. And intermittent bolusing of benzos have been associated with less delirium versus a continuous infusion. So maybe you have somebody who's on propofol, maybe dexmedetomidine, can't get adequately sedated. Maybe giving them bolus doses of benzodiazepine to help them get sedated will provide benefit and efficacy in that realm, but then wouldn't put you at an increased risk of causing delirium. So I do think the risk of delirium is there with benzodiazepines. Is it as prominent as people like to think? I don't know about that. The literature's a little hazy on that.
Well, we sure appreciate it, Philip.
Yeah, I appreciate
Great-
it.
great
I'm
to
always
have it.
around. If you have any questions, I'm around. Aaron's around. Devin's around. Joey's around.
Thank you.
No, thank you.